Welcome, everybody. We're very excited today. Welcome to our webinar on SBRT. And I am very pleased to introduce our presenters. We're fortunate to have two prominent Canadian physicians in the area of oncology speak to us about integrating SBRT in treatment algorithms for liver cancer. Dr. Jennifer Knox is a professor of medicine at the University of Toronto. She's a staff medical oncologist, co-director of the McCain Center for Pancreatic Cancer, Lewitt Chair in Pancreatic Cancer Research. She works out of the Princess Margaret Cancer Center at the UHN. Dr. Laura Dawson is a professor and chair of the Department of Radiation Oncology, University of Toronto. She's a radiation oncologist in the radiation medicine program at the Princess Margaret Cancer Center, UHN. I've had the privilege of meeting both ladies in person. They possess extensive knowledge in their respective areas and have authored numerous papers on the subject. Before we begin, I'd like to ask everybody to put their questions in the chat, and they will be answered at the end of the presentation. Welcome, Dr. Knox and Dr. Dawson.
Thank you very much. It's our pleasure to be here and see some familiar faces. It took a little bit of organization for us to coordinate, so I'm really glad we could do that. And Jennifer and I are both very excited to be here. We do plan to have a lot of opportunity for Q&A. So please do add in your questions as I'm going along, and hopefully we can get to them. So this is a topic that I'd say I'm passionate about, and it's really only been possible with the collaboration of Jennifer and others, and a very strong Canadian team. We'll talk about the role of SBRT for predominantly primary liver cancer, so HCC and cholangiocarcinoma, but some of what we'll talk about could possibly be applied to secondary cancer metastases as well. So I will go over some bread and butter definitions from radiotherapy. Some of them, there are many different terms and acronyms. I think radiation oncologists like that. It's not to hide what's going on, but it can be a little bit confusing. So I'll sort of set the stage. I will then hand over to Jennifer to talk about a patient we shared early on as we were developing the program for SBRT, and then review a little bit about hepatocellular carcinoma, or HCC, and then a little bit specifically about cholangiocarcinoma. Some of the technical aspects of treatment are the same, regardless of the type of liver cancer there is. And as I said, we'll have lots of time for questions. So to start, there are many different ways to deliver radiation therapy. And radiation therapy is one of the pillars of cancer care. It's a little bit, as I said, a black box. People understand what surgery is, systemic therapy or chemo or immunotherapy, but there's a lot less known about radiotherapy, or I guess less awareness in the public about what radiation is. So radiation therapy that we use to treat cancer is referring to radiation that is ionizing, which means it interferes with DNA repair, and it for numerous reasons, causes more dysregulation of a cancer than a normal tissue. But it is a local therapy. There's many different ways to deliver radiotherapy, but unlike systemic therapy, it is delivered only where we aim the radiotherapy, which means we need to know where the tumor is and see the tumor on imaging. And in general, I guess we could break the radiotherapy up into two different ways we deliver it. One is external beam, and one is internal. And external beam is with a treatment unit, often a linear accelerator from afar, which means the unit delivers radiation that then is delivered to patients. And some of the terms or words that are describing conformal radiotherapy refers to multiple beams or arcs where the beam conforms to the target volume. Intensity modulated radiotherapy is one way we do that, where there's collimators in the linear accelerator that vary the fluence pattern of the photons as the beam may rotate. And with that, there's a lot of computer optimization to personalize the treatment and use those technologies to personalize the delivery for every patient. And so those technologies, in terms of the hardware, the linear accelerator treatment unit, but also the software, have really been what's made radiation possible. We can deliver treatment to tumors quite precisely and spare dose to liver that's not involved or other normal tissues. Stereotactic body radiotherapy, or SBRT, or also sometimes called SABR, stereotactic ablative body radiotherapy, all refer to a little bit more conformal radiation with very tight fall off of dose to the target, away from the target. And that has allowed radiation to be delivered in shorter treatments. So anywhere from 1 to 5 typically. That is much more convenient for patients and allows us to give higher dose at each treatment fraction. Each treatment we call a fraction. I mentioned proton therapy. We do not have that in Canada, but it does come up sometimes as perhaps a treatment not proven to have benefits for patients with liver cancer, although there is a randomized trial going on right now. But proton therapy is another way of delivering radiation, and it is the same at the end of how it interferes with the tumor. It's DNA injury. And what is different about proton units are they're much larger, and the delivery of the radiation is at depth with less fall off. And so that is an anatomical advantage for treating targets at depth. But the proton delivery units are not as sophisticated as the photons. So there's pros and cons of all these technologies, and there's many different vendors that deliver radiation. Brachytherapy really means radiation close. It's generally meant or referred to if there's radioactive needles used to treat radiation. So often for other cancers, prostate cancer, gynecological cancers, not so common in liver cancer at all. Occasionally, and in some places, there is radiation delivered via a lumen. So for biliary tract cancers, occasionally may be delivered through the bile duct system. Again, not very commonly used, but occasional protocols would include that. And many of you may have heard of TARE or yttrium-90. So that's a little bit different. Those are radiation that's tagged to a bead that is then delivered through the vessels. So through the hepatic artery into the liver and then directed with an interventional radiologist targeting. I'm not going to speak about that radiotherapy or brachytherapy. I'm going to really focus predominantly on SBRT as the topic today. And just to emphasize, although radiation is very, very effective at injuring DNA and pretty effective at helping us treat cancers of the liver, it doesn't target the microscopic disease. So just to keep that in mind. So what is radiation? So a little bit, the first step is a simulation. And this is something that in the future may not exist, but right now before delivering radiation, there is an appointment that takes an image. And so we on the side, the physics team, it's a whole team that delivers radiation, can work on developing a plan that's personalized. And at that visit, there should be some information about why we're treating, what is maybe some pre-medications or advice. So for example, gassy foods can cause moving gas. And when we deliver radiation, we use imaging to target the radiation, and if there's moving gas, that can cause an artifact in imaging. So that's the reason for avoiding gassy foods. Sometimes there's advantage to empty stomach. We also want to reduce motion. So sometimes there might be pressure on the belly or breath hold, and there's different ways to do this. This is going to age myself, but way back when I was learning about techniques to treat patients with liver cancer, this is before there was breath hold. This is me. So one of the prototypes of working of how to hold breath hold, and this was very clunky and not very comfortable. It's still not comfortable enough for any of you who've used these devices, but it is coming along and steps towards making this more patient-friendly in the future. But the reason for that is to immobilize the liver so that there's less dose to the liver that doesn't need to be treated in the other important tissues. And imaging is key. And so the reason for using IV contrast at the time of the simulation or diagnostic imaging with IV contrast is that IV contrast can show the tumor much better. And without contrast, we're very limited. In fact, cancer can be missed. So seeing where the cancer is close to the time of treatment is very helpful. So generally, we would use contrast. And on the right, it shows these arterial portal venous delay just means, in fact, the details of how the imaging is obtained is a very important, really important part of what we do. I'm going to show a few images of what the units look like. There's many different kinds, and these are some typical linear accelerators that you may see, and they have different casing, and most of the machinery is hidden. One topic just to let you know, and again, these are clinically available units in some centers, is adaptive radiation. Already I mentioned that the treatment can be very personalized to target the radiation to be delivered to the known cancer. But there's further innovations in technologies and software to allow less radiation to normal tissues by adapting day to day. So if one day there's a tumor that may have tilted a little bit, or the stomach's a little bit more full, or there's a little bit less breathing motion, to adjust for those. So those are millimeters difference, but those millimeters sometimes can help. So this is new, but this is just showing there's further advances in the technologies even today that are becoming more widespread that will help with the quality of the care and avoiding and reducing the risk of side effects, and also hopefully allowing treatment to be delivered very much quicker. So this on the right, the CT image guidance system allows imaging for over 6 seconds. So any of you who may have had treatment, sometimes the imaging can take a minute or 4 minutes or even a little longer. 6 seconds is a lot better. So these are some changes in the positive direction to help not only the quality of treatment, but hopefully the experience for patients on the table. On the bottom are just some screenshots of CTs of the actual where the doses are. And so for these examples, the red is where the tumor is, and then the blue is much lower dose, showing that there is some dose to normal tissues, but much lower dose. This is another linear accelerator. This is actually a linear accelerator combined with an MR unit. So one of the treatment units that can deliver adaptive radiotherapy. So I'm going to hand over to Jennifer now to introduce our case when we first started the program many years ago.
Thanks, Laura. Okay, so this is going back a long way now. This is quite a memorable case for both Laura and I. So we got a consult from another hospital of a 38-year-old man who had grown up being a hemophiliac, so he got a lot of blood products. And unfortunately, the blood products, because he has a bleeding disorder, gave him hepatitis C, which gave him cirrhosis of his liver. And then he unfortunately developed the hepatocellular carcinoma in his cirrhotic liver. So he was so young because he had been exposed to bad viruses from an early age. He was, with the cirrhosis, he had, he not only does that lead to risk of bleeding, he being a hemophiliac, not a clotting disorder, had a strong propensity for bleeding as well. And what you can see where we've circled maybe you can show, Laura, because is we had this was a very diffuse and large tumor that was actually invading into the vasculature, right? And so this was not resectable, this was not transplantable. I remember the day I met him because to me, he looked to be, if I can be frank, he looked like an actively dying patient. At the time, this was back in the days where the only systemic therapy was sorafenib, the tablet. It was before the immunotherapy era, and radiation had not been fully established as a treatment. But we did have we had an in-house small trial where we were trying to develop SBRT with sorafenib, but he wasn't eligible, I think, for a number of reasons, but his numbers were way off the chart, and so he just wouldn't make a clinical trial. So Laura and I remember it was before Christmas time, and we decided to sort of treat him outside of the trial, and we would take a chance because he didn't have any other options, and we would do the SBRT and the sorafenib and start the sorafenib early rather than waiting until the radiation period and the recovery period was over, because I guess we thought he didn't have too much to lose. So we went ahead and treated him. Next.
This is the plan here, just to show a little bit of the dose, where it's hard to see, but the bright is the vein, and there should be a vein to the right liver, but it was occluded with the cancer that involved most of the right liver, and so most of the right liver did receive radiotherapy. And then if you look at the time scale, this in the middle is 3 years after we treated him, which is, he had a great response. The liver itself looks quite different. So what happens when there's high doses, the liver can shrink and fibrose, and it turns into a scar. But the bits of the liver that were not treated, in this case, the right side, actually grow and hypertrophy and can compensate. And that indeed is what happened for our patient. And subsequently, you can see there's further, it almost looks like there was surgery, but in fact, that was many years later, having that fibrosis where the right lobe is really eradicated. As Jennifer said, we learned a lot with this patient, as we do everybody. We learn a lot and motivate us to do better and treat better. Yeah, it's one thing. It's nice for us to see such a long-term response when honestly at the time there was nihilism, and as Jennifer said, there was no established role of radiation, and I would say some of our protocols were not being enthusiastically accepted at that time.
And I would say that although I do think that sorafenib may have prolonged his life by, what could have been measured in months, we do think that it was the combination of the radiation with the sorafenib that led to perhaps such a impressive and 6-year response, which was absolutely remarkable, and with good quality of life. And again, in the non-immunotherapy era. And do you want to go to the next one? I'll just talk about vascular invasion before I hand it over to you. From a medical oncology point of view, all these new clinical trials today that study hepatocellular carcinoma with all the immunotherapies and the new things, almost every trial will exclude a patient where the tumor is, where the tumor is working its way into the vasculature of the liver. And so it's very unique to hepatocellular carcinoma that the tumor spreads through the vasculature. And so it's known that these with what we call macrovascular invasion have a worse prognosis. And so part of the reason they're not included in clinical trials, and it bugs me because it's about a third of patients, is that they do worse. And so here is a guy who had that vascular invasion and did so remarkably well. And so it was kind of the case that launched a whole North American-wide trial, which is something we're very proud of. So you want to go to the next? Yeah. So I'll just finish off, Laura, and then you can take over. So this is the publication of this trial, RTOG 112, where basically Laura led this large trial across North America for patients still in the sorafenib era, where you would get stereotactic radiation with the sorafenib or the sorafenib alone. And she's right, there was a lot of nihilism. There was a lot of, oh, this isn't exciting. But at the same time, it was including these patients that had the tumor invading up into their vessels, which is a very common problem that we face. So I'll let Laura, because it's her baby, take over.
Yeah, thanks. I am very proud that this was eventually published. This was a truly an effort, and I would say a Canadian-driven study with largely Canadians, investigators and patients and families supporting it. So thanks to all, and very nice for Canada to be recognized for this practice-changing study. And special kudos to Jennifer. This kind of trial cannot happen with one person. I'm the lead author, but it's impossible for one person to do such a trial. So this study was a randomized phase 3 study, and as mentioned, it was for patients who were not eligible for any local regional therapies at the time, and the oral tablet sorafenib was the standard of care. So the question was, does the addition of radiation improve survival and other outcomes? And half of patients had sorafenib alone, half had radiation with the sorafenib. And this is a summary, just a brief summary of some of the statistics. And just a comment that, so the median some of the tumor was just under 8 centimeters, but up to 19 centimeters. And the majority of patients had multiple tumors. The bright includes the patients who had the drug alone, and the peach color includes the patients who had the radiation, SBRT, and sorafenib. It was personalized dosing, so I would say modest dose to higher dose. And this is the key patient population with that vascular invasion that we were just talking about. 3/4 of patients had that invasion. So at this time, this was the first time this allowed and actually wanted to treat patients where it was difficult to treat. So we did include many patients with macrovascular invasion. And the bottom line is the study did show improved outcomes. So improved overall survival, improved progression-free survival, and longer time to tumor progression. And perhaps most importantly, also with less decline in quality of life and more patients who had improvement of quality of life. So this is looking at quality of life change from baseline to 6 months after treatment. And on the left is sorafenib, on the right is with radiation, and the green is the proportion of patients who had an improvement by 10% or more of the original score. And the yellow is the proportion of patients who had a decline. So less patients had a decline in quality of life. And this were patient-reported quality of life, but it was aligned with the side effects as well. So many patients have side effects, often from the cancer or their underlying liver disease, but also the treatment. And they were similar in both arms. And in fact, the serious side effects or bleeding, where it's sometimes not sure if it's from the treatment or from the cancer, there were less with the addition of the radiotherapy. And that shows that one thing, it's very hard for us to attribute side effects to a treatment versus the cancer, but also that if we can control the cancer well, hopefully there will be less side effects, and this ultimately would improve quality of life. So so that was an important study and put us, I think, on the global scale that we can learn and we can add to the armamentarium, and radiation is a very effective treatment for patients with this challenging situation. This is another linear accelerator. I don't remember where this was, but you can see sometimes some of the rooms have nice pictures, not all, but that's one example of one. So is this the only setting where radiation has a role? We think not. We think many different situations. So I'm going to just briefly go through a few. So there is continuing growing evidence for the use of radiation, not only from our own studies, but from different studies around the world. And early stage unresectable or recurrent tumors where the goal is cure is one group of patients. Another situation is sometimes patients who are having a liver transplant because of very poor liver disease, cirrhosis, and very hard to treat many of these patients as their liver's not functioning well. But if a cancer develops and grows too extensively, that would exclude them from having a transplant. So if we can help keep tumors small or shrink them, more patients could potentially have a liver transplant. We talked about vascular invasion as being a very challenging situation. But what does it mean now that there's immunotherapy and other systemic therapies? We'll briefly talk about that. And finally, to help pain. So radiation is quite effective at pain. On the right here is one of the classification systems. And I pointed out one because it talks about all the different stages of cancer. But at this time, a few years ago in 2022, it still doesn't mention radiotherapy or recommend it. I do believe the next time this is published, hopefully in the next year, they will recognize radiation. And important that it is in these guidelines internationally so more patients and families are aware of this as a treatment option. So this is looking at early stage liver cancer, and this is a recent randomized study. It's for very early, less than 5 centimeter tumors that are recurred despite an attempt with a resection or surgery or radiofrequency ablation. So thermal ablation is usually delivered via a percutaneous needle that can deliver heat and is very effective for small tumors, less effective as a tumor is more than 2 or 3 centimeters. And this was a randomized study. So on this graph, on the right is the SBRT, on the left is the RFA or ablation. And the blue is the proportion of patients where there's been no recurrence at 1, 2, and 3 years. So you can see great majority, 97% of the patients in this study did not have the tumor recur at 3 years following SBRT on the right. And that was a little bit higher than the radiofrequency ablation. So showing it is an effective treatment and hopefully adding this to all guidelines as an option for some patients. And corresponding to this, the survival was also excellent. So these are patients with small tumors, less than 5 centimeters, but excellent 2-year survival of 98% with low toxicity. So reassuring. And this is just, again, the yellow is SBRT, the blue is RFA, and this is at 2 years and at 3 years. Just a second. I hope, can you hear me okay, or is it noisy here? Okay. All right. All right. So I'm just going to, sorry, family's home. I'm just going to text them to keep it down so they don't disrupt us. So yeah. Okay. So moving along, liver transplant I mentioned, and this is a patient who during COVID had a tumor that grew too large, and they were waiting for a transplant and were taken off the list and was quite sick. So their severe cirrhosis was very poor, and in general, there was no treatments that were offered. She and her partner were very articulate. She sometimes had encephalopathy where it was hard to communicate, but between those times, she was very clear she wanted to try to have a transplant. And this was actually, COVID meant we had to give treatments very carefully and in shorter times. And so we delivered a gentle low dose in one treatment and 16 gray. And I think COVID, keeping it shorter was something that we now do offer to some patients, giving treatment in one session, which is convenient. And this low dose led to a great response. 3 months later, her tumor marker had reduced from 4,000 to 300, was small, and she ultimately had her transplant and is doing very well. At last I talked to her as well. So a nice story. It raised awareness to our transplanters and that it is possible to treat even when there's poor liver function, and even low doses can sometimes make a big difference. Vascular invasion we just talked about. So we reviewed that the trial that Jennifer and I led did improve outcomes and help us establish that radiation is very effective. Now, the standard of care for systemic therapy is immunotherapy based, and that is largely possible in many patients, not everybody. And so the question, is there a role? And I would say yes. And the role is, how does it fit? So first of all, not all patients are suitable for immunotherapy. In patients who do have immunotherapy or IO, if there's a recurrence after, they may be eligible for SBRT at that time. And I'm happy to say that there are randomized trials similar to the RTOG 1112 study that are planned to be activated very soon that will hopefully help us learn about the benefit of SBRT in the immunotherapy setting. And in these trials, it sometimes is difficult to not offer SBRT to all patients. We offer it if there's progression or intolerance of immunotherapy for patients when we believe it would be beneficial. We truly don't know if giving it early or with immunotherapy is better than later, and we will find that out in these studies. And I hope and hypothesize that radiation would be a part of care for many patients who are offered immunotherapy upfront. And this is an example relatively recently where immunotherapy, standard of care, and we do recommend that as first-line therapy when tumors do invade the veins. This patient, you can see the tumor here that is the lighter, so involving much of the right liver here. And this little bit here is actually the inferior vena cava up to the heart. So this tumor was invading into the heart. So very extensive large vessels, 17-centimeter tumor. He was otherwise well. This was his first medical problem. He had, I believe, a fatty liver without known liver cirrhosis when this presented. So he was offered immunotherapy, but he had some difficulties. His tumor actually ruptured. That can happen with large tumors. He had a bleed. He was treated conservatively, but his liver function was not so good and immunotherapy was not safe. So there was a change in recommendation to lenvatinib. That's another pill therapy like sorafenib. But very quickly, he didn't tolerate that, had worsening liver function, and couldn't tolerate the lenvatinib. And so we did treat him with low doses. It's about half the dose we sometimes use of SBRT. And in fact, he had a great response. And this is 6 months later, so still some change. And this is one thing with radiation. It's not like surgery where the tumor goes away immediately. We stop it from growing, the scar happens, and sometimes there's less solid lesion. And this is an example, even at 6 months, there's a lot of change, but there's far less active change and even smaller change in the vessel you can see here. And his tumor marker went down considerably. Now, this patient did ultimately develop small other lesions in the liver. And as I mentioned before, this invading into the vessels means there's a high chance of there being hidden cancer too. But fortunately, with the large tumor controlled, he then became eligible for immunotherapy. And so that is another way that SBRT can help. And he is on immunotherapy today. Different linear accelerator, different lighting scheme. So moving on, one other study that actually Dr. Knox and I led in Canada was recently published. So this is a very different use of radiation, but given that it is in Canada, it's not SBRT, I thought it's important to raise awareness. This was led through the Canadian Clinical Trials Group. And it asked the question whether very simple radiation in one dose can help patients who have cancer pain in the liver from primary or metastatic cancer. So very simple, randomized study. And again, half of patients had best supportive care, half had radiation and best supportive care. And it was a quick endpoint at 1 month after the question, do patients feel better? And if yes, terrific. And if they were randomized to not having radiotherapy, they were offered radiation at 1 month. And I think about a third of patients did go on to have radiation at 1 month. And this study was positive as well. So this very simple intervention that's available at every radiation oncology center in the world did improve patient-reported pain. And so although this may seem obvious because we do use radiation for pain in many situations, treating liver pain wasn't in an accepted standard treatment. And I'm happy to say it did change practice. And again, more important than what we see or what we report is how patients and families experience treatment. This was very well tolerated. I do have to say with large volume radiation, it's really important to have medication to prevent nausea. So having a medication to reduce the risk of nausea is very important. And these are some quotes from patients and families. And this, within 2 days, the pain went from a 5 to a 1 and remained that way. And, enjoying quality of life is very important, as you all know. So again, thank you to this was a pure Canadian study. So all the Canadian investigators, patients and families who supported this, and the Canadian Clinical Trials Group for taking on this question that is not a typical clinical trial question. And again, raise awareness in the world of this being an option for many. Another treatment unit, this one I do remember visiting. This was from Korea. So this is in the Asian Medical Society in Korea. And I loved that there was this was about 10 years ago before the green rooms were in. And I thought that was quite a beautiful council for a linear accelerator. So moving to cholangiocarcinoma, all what I mentioned about the technical aspects of radiation and how it works are the same. And historically, cholangiocarcinoma, as many of you know, includes many different diseases. So there's differences in where the cancer is. Is it within the liver, within the biliary ducts, at the bifurcation of the ducts? Gallbladder cancer is a different cancer. In the common bile duct, passing through the pancreas to the ampulla at the duodenum. And the cancers not only anatomically are different, but the genetic mutation is different. And there is differences. And so a little more differences, I would say, in the prognosis and how patients tolerate treatment than other cancers. And with the different locations of tumors, that a little bit affects some of the radiation delivery. For the cancers that are within the liver, away from the main biliary system, short course radiation like SBRT are possible, but there's actually more experience with conformal or longer course radiotherapy. And this was because of the potential for swelling from radiation, perhaps to precipitate obstruction of the biliary system if there's already a cancer there. And sometimes there will be stents that are needed, and that would help prevent that from happening. And for those those tumors that are directly involving the common bile duct. It's a plumbing challenge. If there's a problem there, then there's backlog and jaundice and potential for infection. So that is much more important to consider the dose of radiation every day to not be too high to reduce the risk of swelling, and consider stents. There's more and more experience with SBRT in the intrahepatic lesions, and when there's a stent as well for the extra hepatic biliary cancers. And I suppose one thing just to keep in mind is that if ever there is a recommendation for longer treatment time, the same techniques that can be used to deliver SBRT are available. So those terms are a little bit of a spectrum, SBRT or conformal radiotherapy. Having more treatment doesn't mean the accuracy or quality of the treatment is any different if the same image guidance and motion management is used. So what are the different roles of radiation with cholangiocarcinoma? I guess the first thing I would say, it's been even more challenging to study radiation for cholangiocarcinoma. Although I just presented 2 successful randomized studies that were completed and changed practice, there was also a randomized study even before the RTOG 1112 that we asked the question through the NIH US trials group, how does radiation improve outcomes for patients? And sadly, it didn't accrue. So there wasn't enough participation, and so we didn't get to answer that question. There are a few randomized studies that have been completed in the world, but much less evidence, or at least evidence from randomized trials. Saying that, there is still a growing evidence for radiation, and there's many different ways to deliver radiation, as I mentioned. So SBRT and fractionated radiation I mentioned. Brachytherapy in some centers is used for those tumors that may just line the biliary tract and be small. That is one mechanism, a very good application of brachytherapy. And even without the evidence of radiation improving survival from randomized trials, I would advocate that one important goal is to try to control the primary tumor to avoid the tumor from causing a biliary obstruction or reducing the biliary function, and to preserve quality of life. Saying that, the standard of care for most patients is either surgery or systemic therapy first. So I think that's when we make decisions about when to use radiation, that comes into play. A different role is after standard treatment. Sometimes cancers change, that one of the lesions may grow, whereas all the others are responding to the standard systemic therapy. There's different terms we use for that, oligoprogression, or maybe there's only 1 or 2 sites of tumor that local therapy could address. And so this, I'd say, is perhaps where there's a really strong role of radiation in the future. And I hope maybe we can actually learn on trials and really establish radiation as a complementary therapy to the standard therapies for patients with these situations. And because of the proven role for systemic therapy, usually, at least in my opinion, radiation in these situations would be offered after systemic therapy. Sometimes there may be challenges. So in a situation, if there's a biliary obstruction and an infection, systemic therapy may not be safe. And in those situations, we would consider radiation first. And just like for liver capsular pain, radiation may be used for the treatment of pain from cholangiocarcinoma, but not only from the primary cancer, but pain from other sites. And so always, that's for any patient at any point, if there's discomfort, to consider that. I think I will just end up here. And as I mentioned, we will leave lots of time for questions. So I'm glad we still do have some time. And so I'm not sure, Brenda, if you're looking at the chat, or if anyone has questions, please enter your questions. And I'm sure, Jennifer, you have some questions as well for us. And this is just a little glimpse of the role of SBRT in treatment. I think this is the beginning, and hopefully where they will have a lot more role and benefit for patients as our treatments improve. And I think of radiations, even though it's a bit of a black box, it's quite high tech. It's quite sophisticated how it can be delivered very accurately, but also high touch, like really important that we consider patients as people as we use this technology to help. So thank you for the invitation, Brenda. And I'm happy to be here with Jennifer. I don't know if there's any questions because I don't see the chat.
You have to mute, I think. I think Dr. Knox, yeah, there you go.
Oh, there we are. Sorry, I was muted.
Okay.
Okay, so that was great, Laura. I will comment a little bit that integrating when to use radiation and when to go with systemic takes a little bit of expertise, and good to have a discussion at a multidisciplinary meeting. But I think more and more we're seeing the situation like Laura described, where you've been on systemic therapy, you've had a nice response, but you get a rogue kind of lesion getting ahead, or something is particularly bothersome, or blocking a duct or something. That's where you can kind of break, do the radiation, and then go back to the systemic therapy. So those kinds of things are really hard to prove in a clinical trial. So they tend to be more, anecdotal experience with in big centers and that do that. So we do have a few questions. The first one is just back to your first slide, Laura, about avoiding gassy foods. What kind of timeline? I guess it's how long it takes to digest the gassy food.
Yeah.
Yeah.
It's a good practical question. I added this because it's actually usually not necessarily in textbooks or something that, or it may seem odd as a request to patients, and it's not necessarily needed for everybody. As I mentioned, moving gas can make imaging more challenging, or potentially it could actually move the stomach or bowels towards where we're treating. That's the reason for it. It is not mandatory. So that's the first thing. This is like just sort of a subtlety of what might help the treatment be more effective. And we used to have regimens of actually anti-gas tablets we've tried, but it doesn't work. So just as you can imagine, everybody's individual and everybody knows what might be gassy for them. In general, I would say no carbonated beverages the morning and day of treatment. After is okay. But if you know yourself that vegetables, cabbage, whatnot might cause gas, then to avoid it. But if you don't know, it's okay. We don't recommend any tablets for it. And again, if we actually see gas or moving gas that makes imaging difficult the day of, then sometimes walking moves gas. Occasionally that would be done, or we would chat with you and see, what do you think? And it may be sometimes that some of us are more gassy than others, and that's okay. I mean, we work with it. So there's not any magic answer. I usually would say the morning of. So the morning before the treatment, to at least the carbonated beverages to avoid if possible. Yeah.
So the next question is key, and you addressed it partly. Do you recommend SBRT with the systemic immunotherapy or targeted therapies? And as you pointed out, that it makes scientific sense, especially where in HCC, where there's the vascular invasion, but those are ongoing clinical trials that are trying to sort that out now. Do you want to comment further? I mean, we do it a little bit outside of study for those unique situations, right?
Yeah. And I do think it depends a little bit on your local situation and timelines. So, for some time, we only had one immunotherapy regimen where there was a requirement for checking that there weren't varices, and that took a little bit of time for patients to delay in that therapy. And so if there's known delays for immunotherapy, that might be a window where we say maybe it makes sense to start with the radiation to treat the vascular invasion. I would say for sure anyone who's offered a targeted therapy to consider radiation. It may not be suitable, but if the tumor is mainly in the liver, similar to the RTOG study, then it is worth asking that question if radiation can be offered as a standard of care. Immunotherapy, I hope there's trials, and I encourage any of you to participate in trials if you can. And that is how we learn. And the first point of a trial is best clinical care. So if we really believe that both therapies are needed for whatever reason, that's the treatment we would recommend. And hopefully there will be trials and more trials moving forward in the future.
There's a question about patients who may have metastases in the abdominal nodes. So I'm not sure if that's HCC or cholangio, but would you consider in that situation?
Great question. So yes, there's different anatomical locations that are better suited for radiation and less suited. And for the liver, it's something that's involving the entire liver is not well suited for SBRT. A dose to ablate the cancer is not safe, so there has to be some liver sparing. But the other consideration is other organs, and so stomach and the bowels are sensitive to radiation. And so a tumor that is abutting or invading the bowel is not well suited for SBRT. So it doesn't mean it's impossible, but it's definitely more challenging. Some of the lesions in the nodes, in the retroperitoneal nodes or the nodes beside the vessels, are actually a very good location for SBRT. Many times, if there's many nodes, it may be quite close to the bowel, which would limit the ability to give the higher doses. There may be a role for lower doses for pain control. And those technologies I mentioned, that personalized technology, adaptive radiotherapy, this is something where there's potential that even in a node that is maybe moving around where historically we couldn't treat because there would be a large amount of normal tissue, with that adaptive technologies, that opens the window that hopefully in the future we would be able to help more patients with nodes in those areas that historically were difficult to treat.
So there's a number of questions, I guess, reflecting the cross-Canada participation here, about where is SBRT available with expertise, or is it limited to just a few centers? Is it generally in every province, or?
It's a good question, and it's changing. So I'd say most. I'm not even, I have to be honest, I'm not certain exactly. Many provinces and many centers offer SBRT. We learned that a little bit through the trials. So part of the trials was working with colleagues across the country to allow and teach and credential the high quality radiotherapy. So it's offered in Calgary, in many places in Ontario, Hamilton, Ottawa, Montreal, now in Halifax. And there's interest in other provinces, but not every center offers. And sometimes it's not that they don't have the clinical units, but it's they don't have the experience, or maybe the liver cancer team, as Jennifer mentioned, the multidisciplinary team is so important in terms of making the decisions. So in Vancouver, there's
No, BC?
Yeah, I was just going to say BC has definitely availability. The other thing just to keep in mind is sometimes there's wait time. So right now in Alberta, there's a wait time a little bit. So that may come into play with making some decisions. But it is changing all the time. I'll say we have an education. Actually, one of my slides, I don't know if I have it. I might have it or not. There is you can, if you are welcome to recommend any of your caregivers or radiation oncology centers to talk to me, because we do have an educational once a year series to really help anyone who's interested in developing or improving their program participate. So it's increasing. So widely available, but not every center. I'm sorry, I don't have
I think it's in the next slide, Laura. I think
Oh,
it's in the
okay.
next
Did
slide.
it work? Yeah. Did it? Somehow. Oh, there we go. These are some pictures of cholangio-hepatocellular. This is it. So this is actually our meeting that is going on, and this is an international meeting. It's actually gone on for 20 years, and we have 30 people from around the world who come to learn about how to do this. So we are teaching the world, and of course, we prioritize Canadians and Canadian centers. And so, yes, you can encourage caregivers to come to it for sure. I want to make sure as many people in Canada can learn these technologies.
I just want to add to not being a radiation oncologist, but in being involved in these trials, it's very, very important to have good quality control of how the radiation is delivered. And really old trials maybe didn't have that kind of mechanism. So I know when both of those trials that Laura presented that turned out to be practice changing, the education across North America was huge. And sites, before they could participate in the trial, they had to show that they had the expertise to do that. So you can imagine it's a great way for sites to learn things on the clinical trial. But and I will say, because I can say this because I'm not biased, but it's been one of the problems with some of the radioembolization trials, like the tears in that, is that they haven't had the same kind of rigorous quality control of what is damaging the liver and what isn't damaging the liver, as Laura's work has done. So I tend to be a big fan of this more studied approach. There is a question about how long to wait between the radiation and the start of a systemic therapy, which is a very good question. I don't know if we entirely know, do we, Laura?
Yeah, no.
It's
We
a-
know about safety, how we've done it on trials, and it depends for sure what the systemic therapy is. For the RTOG study with the sorafenib, which I would say is probably we could extrapolate to other similar therapies like lenvatinib. We actually gave the radiation and then the day after started half dose of the sorafenib. Saying that, we made sure patients were doing okay at that time. And this is where it's beyond the technology. It's the team recognizing with patients we need to work together and make sure someone's not feeling too tired or ready to start. So that sequencing works. And then the doses we recommended that being as standard of care. So after that, adjusting up or down depending on side effects. Immunotherapy, yeah, we don't really know. I mean, Jennifer and I have a study we're just in the midst of, hopefully to be published soon, but there's growing experience. What we do from radiation side is if we're a little uncertain, so with immunotherapy, reduce the doses a little bit in some of the critical tissues if we're going to be giving radiation with immunotherapy. And that's partially why we have trials. We do not have that extensive experience about the safety of delivering concurrent immunotherapy and radiotherapy. So there's a little bit of uncertainty. There's other different kind of medications that sometimes may be used that are very strong sensitizers that we would avoid. Like gemcitabine, for example, that's often used for cholangiocarcinoma, is a very strong sensitizer and really important not to give that with radiation and even to wait many weeks, my perspective, even 4 weeks, because there's could be a sensitization that may make the risk of bleeding higher. So it depends on the details, but an excellent question. And again, worth talking to caregivers and your team about it to try to figure out what would work best.
There's a really good question here about trying to evaluate spinal, and I gather it means bone, lesions that have been treated with SBRT and then perhaps look like pseudoprogression or even healing, or how to interpret the imaging afterwards. My approach is if it's feeling better, it's probably getting better, but I'll let you answer.
It's a good answer. It's challenging, and the changes on imaging are very tricky after radiotherapy and different in every organ. Very challenging in liver too. And so I think, when there's a new program, if the radiologists themselves are not used to seeing how changes of radiation happen, there can be sometimes some confusion of the report. So as radiation oncologist, looking at the imaging is so critical, not just the report, and most importantly, how patients feel, for sure. Spine is similar. Bone imaging is a little tricky, and it can be complicated in that there may be fractures. There could be mechanical change as well as cancer. And 6 weeks later is a bit short. It's a bit short. And it's difficult to know, from that particular situation, if it's a pseudo progression, inflammation, or actual progression. And so again, tricky, maybe short-term imaging 6 weeks after would be needed. But again, as Jennifer said, probably symptoms. If there's increasing pain, worth investigating and doing other imaging like an MR to maybe try to figure out what's going on. Feeling better, I would rest assured and wait till the next imaging and fingers crossed it's responding.
I find spine very hard to interpret with imaging, and I do rely a lot on the pain signal. This is a very good question too. How long does treatment take? And I think this probably means how many days or how it's delivered, and of course varies case by case. Yeah, so I think the simple pain management, you can give it in one dose. Some of the cholangio stuff is probably a lot more drawn out, a little bit longer, right?
Yeah, it's it's a good question. So in general, there's a simulation day, so 1 day for planning, and then the treatment days. And SBRT, as I said, is generally thought to be 5 or fewer fractions, but we sometimes would favor longer fractions to better spare normal tissues with a little bit lower dose every day. The other thing is the dose that you may see in your chart or the treatment, the time you're on the table doesn't actually reflect what's happening. So sometimes we may give a lower dose to a bigger region and a higher dose to the tumor. And so it's complicated, and it's not just one dose. It's very personalized. The treatment time on the table depends on the unit. So I'd say in general, probably most commonly 30 minutes to 60 minutes. But the newer units now, 10-minute slots, 10 minutes to 20 minutes. So there's, which is a lot more, I think, a lot nicer. And so hope that there could be shorter treatment times for many more in the future. And those units are becoming more widely available across the country. Yeah.
And Brenna's asking, can you travel out of province and get it in a province where there's an expertise? And I think, yes, you have to get it pre-approved, right?
Yes. Yes. Ideally close to home if it's available. And as we're always happy to do virtual consults and guide, but if not available in a province, absolutely. In fact, pretty routinely, we see some patients from out of province and happy to do that. It's a little more complicated traveling, but it's, we have virtual, at least consults, which are helpful to meet people and then make plans before just flying.
The questions are popping in. Does high dose SBRT cause low platelets? And if so, how long do they take to recover?
Excellent questions. And so, yes, radiation therapy can cause a reduction in platelets. On its own, that is usually something very mild and transient. And someone who may have very large volume radiation and or cirrhosis, so cirrhosis already causes low platelets on its own, and or who's had a lot of chemotherapy, there may be a more propensity to a drop in the platelets. In all of the 25-year experience and trials I've been a part of, the radiation impact on the platelets has been relatively small. So it would be quite unusual for it to go down and stay low for quite a long time. So that's not something we generally see. So I guess the situation could be if the platelets were really low already, they might go down a little bit. That would be in a level that are impactful. Gemcitabine can reduce the platelets. So in someone who's had gemcitabine, there can be a delay in that low platelets. And in that situation with radiation to the liver, that definitely can cause lower platelets. And it may be a longer time for them to recover.
And yeah, I've been treating cholangio for a long time with systemic agents. And if you're doing well and you've been on it a long time, it is a sort of something I see with cholangio that I don't see with other cancers, is that you do tend to get low platelets as time goes on. I think there's probably a complex answer to that, but it becomes an issue with longer and longer term treatment. So it's not always, it's probably more disease and systemic therapy as well. Hi, you're asking when's the best time to engage your local team, and could they perhaps reach out for some advice? Is that what you're, yeah. I think if they don't have experience with SBRT and HCC or cholangio. So Laura probably takes a lot of emails about advice, right? But
yeah, definitely.
Definitely.
And, I'm the name of the first person on the trial, but there are many outstanding radiation oncologists in Toronto, but also in different centers across the world. So very happy to speak to local teams. And I suppose a situation, so as I mentioned up front, we usually would recommend systemic therapy or surgery. But if there is liver confined disease, I would suggest it's worth an opinion. It doesn't mean it's possible, but it's worth an opinion, because after next line therapy, it's something to consider. There are not trials, like we said, but it is a therapy that can help control tumors locally. So that would be what I would say. I would not hold off standard of care treatment to get a radiation oncology opinion. I think that's important, just because we know there are many therapies that are important to start earlier, but at some point, especially if it's liver confined, worth an opinion. And yeah, engage your teams, and we're happy to talk to people. And as I said, I'll invite them to come to our course to try to teach. We really want this to be available for more patients more widely.
And is second line treatment a good time to look for clinical trials or SBRT? So I sound like I'm on my soapbox, but if you have a cholangiocarcinoma, you need to be profiled and early, like before second line, while you're on first line, so that potential plans for second line precision drugs and things can get lined up. So it's good to do that long before you get to second line. And then what would be the best second line for cholangio would have a lot to do with the distribution of the disease, whether there is a druggable target that could be dealt with on a clinical trial, or perhaps if there's a localized area that's causing pain or obstruction or recalcitrant to chemo when the rest is responding, would be a time to think about radiation. Would you add anything to that?
Yeah, no, these questions are outstanding. I'm not surprised with this group, really good questions, very thoughtful. I agree. And if there's an opportunity for a mutation with a druggable treatment, that can be really changing. And that's really important not to miss that opportunity. In patients where there's not an actionable mutation before second line, I hope, and I don't know if this is possible, that could be an opportunity for trials where changing to second line standard chemotherapy or adding in radiotherapy might be something that we could help patients with. It's not standard yet, but I think that's a good opportunity to consider it, but not to withhold a therapy that might be very, very effective. So again, very dependent on what are the options for the second line and what is the distribution of the disease.
Another scenario that just came to mind with HCC, we need a good functioning liver to be able to deliver systemic agents. Sometimes a patient presents with so much macular vascular invasion that it's starting to cause the liver function to deteriorate quite quickly. Laura and I have a few examples where she has started with radiation because the patient wouldn't have been well enough to metabolize drugs, and there's been an improvement in the liver function because of the response from the radiation in the vasculature. And then it's allowed us to move on to systemic therapy. So it's a bit of a nuanced decision-making process, but again, these cases need to be discussed at a multidisciplinary tumor board where you have some expertise from all sides.
Yeah. And then I think the question about availability and expertise, if teams are hesitating, radiation oncologists aren't comfortable, that's okay. It means that, because it is, as Jennifer said, the attention to detail matters a lot. So they can learn the skills or they can refer. You don't want someone to give you treatment if they're not going to be, looking at liver function and the whole picture and speaking to the entire team to make sure there's the right therapy. So anyway, it's tricky, right? It's a little bit tricky, and there's a learning curve, hence why it's not available at absolutely every center, but hopefully soon in every province. And it is available in BC. Vancouver Island, definitely available.
So I think, Brenda, we've worked our way through all the great questions. Maybe anyone else have anything? That was a good discussion.
Fantastic questions, very impressive.
So basically, was this answered? How long is the break between radiation and systemic treatment? I think somebody came in late.
Yeah, it's one of those situations where we really don't know, and we use a little bit of judgment, especially depending on whether it's a dangerous area that was radiated versus a more inert area, I guess. But generally, minimum a good week or more.
Okay. So what the information is, it's not black and white. It sounds like it's a lot of gray where you guys have to look at every case separately. I would like to thank you very much for such an informative presentation. You've answered many questions that patients and caregivers have about SBRT and radiation, and I think you've inspired hope.
Wonderful. Thank you to you and everybody here for also inspiring hope and inspiring us and sharing the message and with the community. It's a wonderful group of people. You guys are amazing.
Yeah, Brenda, it's fantastic. How often do you do these for everyone?
Well, we did a dietitian's presentation in May, and we've done some grief ones, and we've done compassionate fatigue, but to get the high-powered physicians, not as much. So Howard Lim's going to do one in October for us. So
can I end up with a funny story? Laura's very famous in radiation. I might be a bit famous in other things, and we're both Canadian and we're both women. And so when we go around the world, especially, people start talking to me like I'm Laura Dawson, the radiation doctor. And I think occasionally she might get mixed up for me.
That's true.
I think it's really quite funny. It probably doesn't happen with men.
Yeah.
But anyway,
our Canadianism, Canadian leaders in liver cancer. I always will take it as a compliment, and hopefully you too.
I take it as a compliment too.
There's a lot of thank yous here in the chat box, and you guys are just wonderful. I mean,
thank you so much.
You don't even look alike.
We don't even look
the
alike.
twins.
No, we're just Canadian women. Thank you so much, everyone, and we wish you all the best. And I do think your local teams would be happy to reach out and ask questions. We do answer a lot of questions all the time.
Absolutely. And have a lovely long weekend, everybody, coming up.
Right. Yes. Thank you so much for taking the time out of your busy schedules. I know you are so busy, so I really appreciate it.
Our pleasure.
Our pleasure.
Yeah.
Night, everyone.
Thank you.
Good night.
Good night.
Bye.